Good afternoon to our audience in Europe, Asia, and Africa region, and welcome to the Thyroid Federation webinar on the thyroid rare disease MCT8, also called the Allan-Herndon-Dudley syndrome, AHDS. This webinar is brought to you just before the Rare Disease Day, which is on Saturday, 28th of February. Today, the lecture is being delivered by Dr. Edward Visser, whom I should introduce to you very shortly. I am the host and your facilitator, and this webinar is also brought to you by Cleveridge, Carlos, behind the scenes. And I am Ashok Basin, President of Thyroid Federation International. On behalf of the board and its members and supporters, we are able to bring this webinar to you today. So thank you all for joining us today. If there are any questions, just write it down in the Q&A, and we will get back to you. Dr. Visser will answer those questions, and we will deliver those questions to you. We have to do this because everybody joining us today are very, very busy people, and in the interest of time, it'll be nice that if you can just put down the questions, and we can get back to you today. So we'll move on to the next slide. Now, Thyroid Federation International is a 31-year-old organization, and we are an evidence-based organization. Thyroid World Day, 25th of May, was originally created by us in 2009, and it is followed by everybody across the globe. We also have, for 19 years now, Thyroid Awareness Week, which is from May 25th to 31st each year. We are proud members of European Thyroid Association, Latin America Thyroid Association, American Thyroid Association, Asia Oceanic Thyroid Association, and EUROID, so the Rare Disease Europe, NCD Alliance, we work with them and with WHO, and also World Iodine Association, European Society of Endocrinology, and Thyroid Cancer Organization. So it's good to be with all of them and good to be presenting you with this webinar today. I'll move on to the next slide. I wanted to thank Merck AG, Germany, and Amgen, Viridian, Immunovant, Aegis Therapeutics. Without the support of all these organizations, it will be very difficult to bring webinars and quality programs to you. So thank you very much to all our sponsors for helping us bring this. Now, I would like to introduce you to Dr. Visser, MD, PhD, from Erasmus University in Rotterdam. He's a professor in the Department of Internal Medicine at Erasmus MC University in the Netherlands. His doctoral research was and is focused on the importance of thyroid hormone transportation deiodine in the pathophysiology area. Dr. Visser, he got a European Marie Curie Fellowship that enabled him to follow a postdoctoral fellowship in 2013 at the various Dutch, European, American subsidiaries that enabled him to carry on his research further. He conducted an international multi-center trial in which the effects of the triac medication were to be investigated in patients with Allan-Herndon-Dudley syndrome, mutations of MCT8. He also investigates the role of thyroid hormone during aging. Dr. Visser has published more than 40 international scientific papers and is constantly doing many reviews in many journals in Europe. TFI is thankful to Edward Visser for his contribution today and putting this presentation together. Thank you so much to Dr. Visser, and thank you so much for doing this for us today and bringing this to you. So over to you, Dr. Visser.
Hello, good afternoon, or good morning, or good evening. My name is Edward Visser from Rotterdam, the Netherlands. I'm an endocrinologist, and I have an academic interest in thyroid hormone signaling, particularly how thyroid hormones enter the cell and what happens if this process is disrupted. So today I will focus on MCT8 deficiency. This is my disclosure slide. And what I would like to do today is to start with a brief context of thyroid hormone signaling. Then I will discuss the main clinical and biochemical features and mechanisms of this disease. Afterwards, I will spend some time on genotype-phenotype relationships. And the last part of my talk will be on treatment for MCT8 deficiency. So let's get started. So this is a T3 target cell. So you do see the plasma membrane and the nucleus inside. And as you know, thyroid hormone acts inside the nucleus by binding of T3, the active form of thyroid hormone, to its receptor, the thyroid hormone receptor. Inside the cell, there are a couple of enzymes called the deiodinases that can either activate or inactivate the thyroid hormones. And as these processes of thyroid hormone action and thyroid hormone metabolism occur inside the cell, the hormone needs to be transported across the plasma membrane, which is a process that is facilitated by transporter proteins located at the plasma membrane. Actually, MCT8, monocarboxylate transporter 8, is one of the key transporters for thyroid hormones, and hence the focus will be on this one today. So this was actually published in 2003 by Visser et al. So what you do see here is on the y-axis the uptake of thyroid hormones. Underneath the different iodothyronins and other substrates, which were exposed to oocytes that were either uninjected in red or injected with red MCT8. And as you can see, there's a clear accumulation of the different iodothyronins, including T4 and T3, in oocytes expressing MCT8. So what happens if MCT8 gets defective? So the gene encoding for MCT8, SLC16A2, is located at the X chromosome. So that means that mainly males are affected. And that occurs around 1 in 70,000 male individuals. And it's important to realize that there are two components to this disorder. There's a neurodevelopmental part and a metabolic part. And we'll touch upon both of those components today. So here I showed you some photos of patients in my clinic that really highlight some key aspects in this disorder. So on the left-hand side, you do see a patient who has no head control. He needs hands to support sitting, so he cannot sit independently, which is caused by the truncal hypertonia. He also has a low body weight and feeding problems. The patient on the right side, he's wheelchair bound, he has dystonia, and in fact there are many other aspects of this disorder which you do not see on the photo, but they clearly can suffer from those. Now, how do you define the spectrum of clinical features and biochemical features in such a rare disorder? So we had the privilege to coordinate an international consortium from which we obtained different types of data: biochemistry data, developmental data, clinical data, and also mortality and causes of death from many countries in the world. And I will show some of the key aspects from that consortium in the next couple of slides. So let's see to move on. Yeah. So here you see the most important clinical features listed. So for example, hypertonia, the persistence of primitive reflexes, dystonia, spasticity are present in the far majority of patients. Also, feeding problems, hip luxation, but also sleep problems occur at varying rates in such patients. The absence of head control, the absence of sitting, speech, and walking is also present in the far majority of patients. So how do these patients present for the first time? So actually the most common reasons for referral are the presence of a gross developmental delay, so patients do not reach their early milestones, and also the presence of hypertonia. When you would measure thyroid function test in such patients, they virtually all have the same very typical abnormal thyroid function pattern. TSH concentrations are typically within the reference interval. T4 or free T4 concentrations are typically low normal or low, while the T3 or free T3 concentrations are typically elevated. And it's particularly this abnormal ratio between T4 and T3 that is distinct in this type of patients. And that leads to the question whether you would be able to detect this disorder already at birth, given the presence of neonatal screening programs in many countries. So if you would measure TSH, which is present in most neonatal screening programs, you would not detect this disorder because TSH is typically within the reference range, and that's also the case in newborns. However, should you measure T4, like we do, for example, in the Netherlands, you can see that the majority of patients that we were able to retrieve neonatal screening current results from are below a certain value that would refer them for further investigation. In this particular case, in the Netherlands, TSH is measured if T4 is abnormal, and at that time it was concluded no thyroid disease. So recently, studies from another group also confirmed that T4 concentrations are low in patients with MCT8 deficiency compared to controls. Likewise, also reverse T3 concentrations were low, but T3 concentrations were similar to controls. So already at birth, there clearly is an abnormal ratio of T3 and T4. So should this be confirmed in the future, this might be a lead to try and get this disorder into neonatal screening programs. So when does this diagnosis typically happen? So we were able to collect data on this topic, and typically there's a difference between the onset of symptoms, which typically occurs during the first months of life, and the diagnosis. So this had a delay of 19 months. Patients born after 2017 had a much quicker diagnosis, although there was still an 8-month delay in the diagnosis. So typically these patients nowadays get diagnosed either because the doctor is aware of the existence of MCT8 deficiency or through a genetic diagnosis, typically through a genetic panel. But obviously, as you can see, there's still room for improving the diagnosis earlier in time. So this figure shows how severe the delay in neurodevelopment is. So on the y-axis, you do see a score, which is the gross motor function score, the gross motor function measure, the GMFM-88, in which 100% represents the normal motor capabilities that a healthy 4-year-old child has. And as you can see, all patients, irrespective of their biological age, have a very low score. So typically that equals a developmental age of around 2, 3, 4 months of age. So a pretty severe neurodevelopmental delay. So what about their thyrotoxic or metabolic phenotype? So this is really exemplified in the body weight. So here on the y-axis, you do see the body weight corrected for age. So in the gray dashed area is the reference interval for healthy individuals. And here we plotted the age of the different body weights for patients over time. And as you can see, they're born typically with a normal body weight, but they deteriorate during the first years of life and also further during puberty. Likewise, they have a elevated heart rate, so they have tachycardia, which is present in, or tachycardic events present in many patients. They have a very high number of so-called premature atrial contractions, which is rather unusual to occur in children, and also they have other cardiovascular abnormalities. So from the parent perspective, you are able to collect data what parents feel as the most pressing issues in daily life. And they mention things like mobility issues, feeding, sleeping, their limited motor skills, the problems with communication really pose huge challenges during daily life in the care for children with MCT8 deficiency. So together, this disorder has a high mortality risk. So around 30% of patients die during childhood. So of the causes of death that we were aware of, the majority is caused by aspiration, by pulmonary tract infection, and by sudden death. And although we don't know the causes of sudden death, it might be tempting to speculate that, for example, cardiovascular issues, rhythm abnormalities might contribute to this high occurrence of so-called sudden death. So what is the pathophysiology of MCT8 deficiency? And I apologize for not being able to show all the data underlying the cartoon I'm going to present, but many different research groups over the world in different model systems, in cells, in fish, in mice, have really contributed to this idea. So cells and tissues that are dependent on MCT8 for their intracellular thyroid hormone bioavailability will be in a hypothyroid state if MCT8 is defective. So the T3, the active form of T3 of thyroid hormone cannot enter the cell. And because MCT8 is importantly expressed at the blood-brain barrier and also in neural cells, there's a largely reduced entry of thyroid hormones into the brain. And as thyroid hormones are important for a normal brain development, it's understandable that if that's deficient, it results in severe intellectual and motor disability, as we see in such patients. At the same time, other cells and tissues that do not depend on MCT8 but on other transporters will be exposed to the high T3 concentrations that are present in these patients. And that results, for example, in tachycardia in the heart, in muscle wasting, and we feel also contributes to the increased mortality in these patients. So let's dedicate a few slides to the spectrum of the disease, the genotype-phenotype relationships. So over the years, we became increasingly aware that, yes, the majority of patients do not have head control or have no verbal communication and are severely underweight, but some of them are able to walk a bit and also to pronounce words, etc. And likewise, some of them are able to maintain normal body weight and heart rate. So what underlies these observations? So to address this question, we collected data by expanding our international consortium, by really scrutinizing the literature, and then we were able to collect different types of data from close to 400 individuals. We were able to test all the individual mutations in MCT8 with functional studies in different cells, also in patient fibroblasts. And then we started to link the genotype to the function and to the phenotype. And I will show some data on this. So this slide shows actually the map with MCT8 mutations across the different transmembrane domains. As you will see, It's spread across the protein, but there are also certainly certain hotspot regions in which independent mutations occur. So they occur in different families independently. So then we started to test the function of all these different mutants. So on the y-axis, you do see the T3 uptake. So 100% is a completely normal MCT8 protein. And here are all the different variants that we tested. And as you can see, the majority of patients have a severe loss of function. And the rest falls in different other categories with moderate and mild loss of function. So then we started to stratify different outcomes according to these different loss of function categories. And as you can see, patients that have a severe loss of function have a much worse survival than those with a moderate or even mild loss of function mutation. And we did see that same pattern actually for virtually all disease features that we tested. For example, T3 is also higher in the severe loss of function than in the milder. The 3T4 is also less outspoken or more outspoken in the severe than in the mild. Likewise, the neurological phenotype, there is way more head control and sitting and walking present if patients have a mild phenotype compared to or mild loss of function mutation compared to a severe loss of function mutation. So I'll make one side chat to females with MCT8 deficiency. So as I mentioned before, MCT8 encoded by SLC16A2 is located at the X chromosome. So that means that normally patients have a wild type in half of their cells, but may have a wild type MCT8. However, in patients that have a unfavorable X inactivation, they could have a preferential expression of the mutant MCT8. And that's what we noted in a small study we did with in a collaboration with quite a couple of physicians across the world. And what you do see is the biochemical picture is similar to what we see in male patients. So they have a low 3T4 and they have an elevated T3. However, what was mostly striking is that their neurological abnormalities ranged from a really kind of full overt male MCT8 deficiency phenotype to much more subtle behavioral psychiatric features. And that leads us to hypothesize that there's actually an entire spectrum. So at the one hand side, there are patients, male patients with MCT8 deficiency with severe, moderate, mild loss of function. On the other hand, there are the completely normal of individuals with a completely normal MCT8 function. We have also some data, I'm not showing it today, that common genetic variation also has some minor impact, perhaps on MCT8 related traits. And with the females, some of them are somewhere in the middle. So there's there could be an entire spectrum of different features dependent on the level of abnormality in the MCT8 protein. And that poses the question whether we are able to accurately predict pathogenicity in MCT8 variants, which is particularly pressing in this era of next generation sequencing. So when using current prediction tools like Polyphen or SIFT, you do see that they have quite a not so good predictive power for MCT8 variants. So that led us to try to improve this. So based on all our functional data from patients, but we also did an entire alanine screen of the protein. I won't go into the details today. And in collaboration with some really nice people who were good in building such classifiers, we were able to build an MCT8 specific classifier with actually good accuracy rate. And that led us to build such a map, an MCT8 landscape for over 8,000 potential variants, which we hope might be useful for the field. So if there's a new mutation found, people can go through kind of the supplementary table of this publication, and they might look up what the probability is that a certain mutation is pathogenic. And actually, we also build a feature that you can distinguish whether it's severe or less severe impact mutation. All right, so let's move now to the treatment of MCT8 deficiency. So over the years, different therapies have been explored for MCT8 deficiency. I've listed them here. So LT4, PTU, LT4, T3 analogs, chaperones, gene therapy, levodopa. They have been tested in mice and humans. I've listed the key studies here on the right side. Today, I will mainly focus on triac because most of the data is present for triac. But I'll briefly touch upon some other therapies. So in the past, levothyroxine has been empirically tried in quite a number of patients because physicians suspected individuals of a central hypothyroidism because their TSH concentrations were normal and their free T4 concentrations were low. So if you don't measure T3 at that time, you might think, well, this is a patient with a central hypothyroidism and we should supplement that patient with levothyroxine. However, if you do that, that kind of aggravates the thyrotoxicosis because the type 1 deiodinase is actually pretty active in such patients. So the T4 you give is immediately converted to T3. So we advise against the use of levothyroxine. So recently a paper was published on the combination treatment of PTU and levothyroxine with the idea to kind of block the thyroid gland, but more importantly, to also block the type 1 deiodinase, which importantly contributes to the high T3 concentrations in such patients, and then supplement with levothyroxine. And what these investigators noticed is that T3 concentrations were reduced, free T4 concentrations were increased, body weight increased in some individuals, but not in all of them. And on the group as a whole, it was not statistically significant. So yeah, we are unsure whether this would change if they would have tested, we're in a position to test a larger group, but obviously this is a rare disorder. So what we conclude from this is that PTU levothyroxine has beneficial effects on the thyroid function tests, is not evident on other parameters. On the neurological outcomes, you cannot really expect something. And it's important to realize that PTU can have serious adverse effects with, and it's generally recommended against in pediatric guidelines. So it is something you might consider, but only with proper counseling, obviously, of the parents regarding these liver effects, particularly because the livers of such patients are already quite vulnerable. Around half of them have already elevated ALT levels in the untreated condition. Recently, 2 papers were published, 2 observational studies in which patients were treated with levodopa, carbidopa, with the idea that certain movement abnormalities were reminiscent of some Parkinsonism features, and they noted that improved in the patients they tested. So when we started to think about a potential therapy, I think over 10 years ago, we had a very simple idea, namely, one would like to increase thyroid hormone action in the hypothyroid tissues and to reduce the thyroid hormone action in the thyrotoxic tissues. And we made use of a T3 analog called triac. On the right-hand side, you see the molecular structure in which TRIAC is very much similar to T3, except that the side chain is just a little bit different. And the idea would be is that TRIAC enters the cell through another transporter, but once inside the cell, it can act like T3. So it can enter the cell independent of MCT8. So at the time we hypothesized this, we were not aware of which transporters would do that. In the meanwhile, we and another group have started to identify different transporters that have the possibility to transport TRIAC. If you want to read further on this, you can go to these references. So how would TRIAC work in these patients? So on the right-hand side, you do see the let's say the mechanisms of disease, so the hypothyroid and the thyrotoxic part, with the abnormal thyroid function pattern in the middle. So the hypothesis would run like this. So TRIAC enters the cell in which MCT8 is expressed, but it enters the cell through another transporter, giving some thyromimetic action into the cell. So TRIAC works like T3 in such cells. And because the pituitary is relatively insensitive, because MCT8 is also defective in the pituitary, that would result in a decrease in TSH, leading to a decrease in endogenous thyroid hormone production. So an further decrease in T4, but also a potential normalization of T3, which has positive effects on the tissues which are not dependent on MCT8. They will be exposed to lower concentrations of T3. So will this work? So we had different preclinical studies. So this is a very elegant study performed by the group of Heike Hoyer in Germany. So these are Purkinje cells of wild-type mice. This is what happens with the Purkinje cells in a mouse model for MCT8 deficiency. So clearly the development is disturbed. But when these animals were treated right after birth with TRIAC, this was completely reversed and they had a normal brain development. So together with other preclinical studies, we thought, okay, perhaps we should start to study this in patients. And we decided to first focus on the metabolic phenotype or the thyrotoxic phenotype. So we initiated a trial which ran in different countries. We were able to enroll 46 patients with a median age of around 7 years, and we treated them for 12 months with TRIAC. So we were able to show that the T3 concentrations, I mean, here are all the individual patients plotted, which were elevated at the beginning of the trial, all decreased. And in the majority of them, they were within the normal, or actually in the target range. And that actually went hand in hand with improvements in body weight. Again, this is body weight expressed for age. And as you can see, the majority of them were well away from the reference range in healthy individuals. And also at the group of a whole, there was a statistically significant increase and also a relevant increase in body weight. Perhaps following the high T3 concentrations, reduction in the T3 concentration, there was also a reduction in heart rate, particularly in those that had an elevated heart rate at baseline. And likewise, the occurrence of premature atrial contractions also subsided in the far majority of patients. Other biochemical markers that reflected thyroid hormone action in different peripheral tissues also improved, exemplified here with SHBG, which is T3 responsive in the liver. So these data were obtained in a trial setting, but then we started to wonder, okay, what happens actually in, I apologize for this, in real life, in the patient, which is really in front of you. And we collected real world data, actually with the same outcomes as in the trial, from different countries. So the more intense the color, the more patients we retrieved from that particular country. And actually, we were able to confirm the same reduction in T3 concentration. So T3 reduction is really sustainable, also over a longer time period. So this is a rather complicated slide, but I will try to guide you through this. Again, on the y-axis, the body weight for age. In gray, the reference range for children. In orange, plotted the natural history of untreated MCT8 deficiency. And then the blue lines, they indicated patients that are on triac. And as you can see, the majority of patients either stabilize or improve. And when you do the calculations, the statistical test, that was also statistically significant. We also show that triac is effective irrespective of the underlying type of mutation. So as shown here, T3 is reduced in patients with severe, but also in moderate and mild loss of function mutations. And likewise, body weight corrected for age also improves irrespective of the underlying loss of function category. So is triac effective in patients with MCT8 deficiency when it comes to the thyrotoxic or metabolic phenotype? I think based on the trial data and the real world data I showed you, we believe the answer is yes. And actually that also led to the approval of triac by the European Medicines Agency about a year ago. So what about the other question? Does it improve the neurological phenotype? We have run a second trial in young children with high doses of triac to see whether we could improve the neurological phenotype. We haven't analyzed all the data in detail as yet, but the high over data seems to show that the answer is no. Again, we need to really dive into this further, and it has not been published as yet. Perhaps some practical advice. So if people would consider to start triac, it's important to realize that if you use immunoassays for T3, actually in a majority of immunoassays, there's interference with triac because it's so similar to T3. So for that reason, we make use of an LCMS assay that we established in our center, obviously that has no interference. We measure both T3, T4, and triac. We have established a target range specific for the LCMS. So should there be physicians who want to treat patients with triac and would like to get some advice, feel free to reach out to me. We are happy to facilitate. Obviously, there are many questions to be addressed in the future. So what is the optimal dosing? Should you also treat patients with mild loss of function mutations? Would you be able to perhaps rescue or improve the phenotype if you were able to administer triac before birth? Would it be possible to get this disorder into the neonatal screening, and so on and so forth? So this is my pre-final slide. So what I hope I have shared with you is to say that thyroid hormone transporters, and particularly MCT8, are relevant. That a deficiency in MCT8 gives a complex phenotype arising from hypothyroid and thyrotoxic features. There's an entire spectrum of features which depend on the underlying genotype and is a relationship with the loss of function category. Triac is able to alleviate the metabolic and thyrotoxic part of the disease. It seems it isn't able to improve the neurodevelopment in young patients, and together this resulted in the approval by the EMA last year, and the process at the FDA is underway. So how I view this triac is that I'm not saying it is the golden bullet, but it's certainly doing something good for these patients. This is my acknowledgement slide. I'm extremely thankful to my team and particularly to the different researchers involved in MCT8 and TRIAC, Stefan Groeneweg and Ferdy van Geest, Floor van der Most and Matthijs Freund. I'm really happy to collaborate with so many doctors and researchers on MCT8. I'm very thankful to collaborate with many physicians and research nurses across the globe who are very dedicated to contribute and to improve the conditions for patients with this rare disorder. Thank you very much.
Thank you so much, Dr. Edward. That was an excellent presentation. And you make it so easy for people to understand. And conceptually, everything's so clear and very well presented, very well put. Thank you very much to you and your team for conducting all the work behind this and putting this presentation together. We really appreciate your work. Thank you very much. And now I would like to thank our sponsors once again: Merck, Germany, Amgen, Immunovant, Veridian, Agitus Therapeutics, for helping us bring this program to you. And what is next? Before that, we will once again look at all our members. We are proud members of Uroids, WIA, ETA, ATA, LATS, IOTA, NCD Alliance, American Society of Ophthalmic, Plastic and Reconstructive Surgery, European Society of Endocrinology, and Thyroid Cancer Organization. So thank you all very much. And what is coming up in the future? So we have webinars on thyroid eye disease and Graves in May 25th, 2026. That is during the International Thyroid Awareness Week. And again, we have hypothyroid issues on May 31st, 2026. And then thyroid cancer webinar in September. So you will be receiving mails for all this for registration. And what is very exciting and what we are very excited about is the upcoming thyroid podcasts. That is going to be between patient doctors and sometimes between patients and patients. That will help us relay this to the patients who are suffering from various thyroid issues, and they can understand and manage it better. So once again, I would like to thank each one of you for joining us today. And if there are any Q&A, which I see few, you will get those answers. So directly from us or from Dr. Visser. Thank you very much. And thank you all for joining today and helping to make this program a success. Bye for now.